Role of ultrasonogram in chest disease Part 2. Presented by Dr. Jalal Mohsin Uddin, Assistant Professor, NIDCH, Mohakhali, Dhaka. Presentation related to chest wall, diaphragm and pleural effusion. Index. Structures evaluated by chest USG Slide 3. Chest wall evaluation Slide 4. Evaluation of position, morphology and motility of the diaphragm Slide 11. Technique for the assessment of the paralysis of the diaphragm Slide 15. Pleural effusion Slide 20. Measurement of pleural fluid quantity Slide 32. Structures evaluated by chest USG. According to anatomical location, chest diseases can be divided into following groups: chest wall, position, morphology and motility of the diaphragm, pleural pathology, pulmonary pathology, mediastinal abnormalities, extrathoracic abnormalities, chest wall evaluation, musculoskeletal, subcutaneous structures, etc. can be evaluated better by linear probe, 8 to 12 MHz. Linear probes are also useful for detailed study of the pleuroparenchymal interface, layered structure of the thoracic wall, skin, adipose tissue, intercostal muscle, rib, acoustic shadowing, pleuropulmonary interface. Chest wall evaluation continue. Fractures of the rib and the sternum can be seen well on ultrasound. Fracture diagnosis by ultrasonography is not only much more sensitive than conventional X-rays, but also demonstrates accompanying soft tissue lesions and hematomas reliably and rapidly. High-resolution sonography was performed using a linear 5 to 12 MHz transducer. Rib fracture, discontinuity of the bone cortex surrounding of a small hematoma. Chest wall evaluation continue. The tentative statement about the malignant or benign nature of a lesion constitutes an important reason to perform an ultrasound investigation of the chest wall. Chest wall evaluation continue. Malignant tumors usually have irregular margins, inhomogeneous structure and a tendency to invade the pleura and the skin. They also present vascular signal upon Doppler investigation. In the order of their occurrence frequency, soft tissue sarcomas are predominantly fibrous or fibrohistiocytic, 50%, followed by liposarcomas and nerve sheath tumors, each 14%, muscle tumors, 8%, vascular, 4%, and synovial tumors, 2%. Malignant fibrous histiocytoma, almost round, hypoechoic, inhomogeneous mass, extending towards the skin. Chest wall evaluation continue. Benign tumors such as lipomas or fibrolipoma. These are well circumscribed, usually hypoechoic, relatively homogeneous and hypovascular. Thoracic wall lipoma, oval, flattened, hypoechoic, almost homogeneous, well circumscribed mass. Chest wall evaluation continue. A secondary malignant invasion of the chest wall may be realized through local extension in the case of lung cancer, pleural mesothelioma, breast cancer, or from any other distant sites. Soft tissue metastasis meet the malignancy criteria. They are poorly circumscribed, hypoechoic, inhomogeneous. Ribs, sternum and scapular metastasis lead to bone fragmentation with perioceous extension, usually hypoechoic. The mass is also present vascular signal. Rib metastasis with irregular bony contour. Chest wall evaluation continue. In case a puncture needs to be performed prior to treatment, ambiguous lesions in the chest wall can be easily accessed for an ultrasound-guided puncture and subsequent histological confirmation of the diagnosis. The risks associated with puncture are very low because of the convenient location. In cases of proven malignancy, lesions of the chest wall can be monitored during treatment. Evaluation of position, morphology and motility of the diaphragm. Ultrasound imaging is a non-invasive, radiation-free, accurate and safe technique allowing assessment of diaphragm anatomy and function. The transducer is placed in the anterior subcostal region between the midclavicular and anterior axillary lines. The ultrasound beam should reach the posterior part of the diaphragm. In the B-mode view, the diaphragm is identified as an echogenic line between the interface of the lung and liver or spleen. Evaluation of diaphragmatic motility. Diaphragmatic motility is evaluated by using a 2 to 5 mmHz convex probe. Patients are examined in supine position. A right ascending subcostal scan in the area between the anterior axillary line and the midclavicular line is employed. Diaphragmatic excursion is the movement of the thoracic diaphragm during breathing. Normal diaphragmatic excursion should be 3 to 5 centimeters, but can be increased in well-conditioned persons to 7 to 8 centimeters. This measures the contraction of the diaphragm. Evaluation of diaphragmatic motility continue. Diaphragm is examined in B mode, and respiratory excursion is evaluated in M mode. Examination consists of measurements of the inspiratory phase at rest and after deep inspiration. After freezing the image of the diaphragmatic curve during the respiratory cycle and measuring the distance from the base of the curve to the apex. Figure 2. In A, measuring the excursion of right hemidiaphragm using the anterior subcostal view with the convex probe positioned below the costal margin between the midclavicular line, MCL, and anterior axillary line, AL. In B, ultrasound appearance of the right hernidiaphragm in the subcostal region between the MCI and DAL. In C, schematic representation of the measurement of diaphragmatic excursion, on the left, placement of the probe in the subcostal region to display the diaphragm in B mode and placement of the exploratory line demonstrating exartica from expiration to inspiration, point say 8. In D, measurement of diaphragmatic excursion in M mode. The top of the figure depicts the normal right diaphragm in B mode, and the bottom portion depicts M mode ultrasound of the diaphragmatic excursion during quiet breathing, QB, deep breathing, DB, and voluntary sniff, versus. Technique for the assessment of the paralysis of the diaphragm. Patients are imaged using a 2 to 5 mmHz curved linear transducer. The patients are asked to breathe comfortably and to sniff when requested. Patients are scanned intercostally in the anterior axillary line with the probe angled cranially so as to have the diaphragm as close as possible to 90 degrees to the probe. The liver is used as a window on the right while the spleen is used on the left. If unilateral paralysis is suspected, the normal side is scanned first. M mode is performed in conjunction with conventional brightness mode, B mode, grayscale ultrasound. Technique for the assessment of the paralysis of the diaphragm continue. Normal inspiratory diaphragmatic movement is caudal, with the corresponding M mode trace being upwards as the diaphragm moves toward the probe. The expiratory trace is downwards as the diaphragm moves away from the probe, cranially. A normal sniff is demonstrated as a sharp upstroke on the screen, whereas a paralyzed diaphragm will either demonstrate absent movement or paradoxical, cranial, movement. Technique for the assessment of the paralysis of the diaphragm continue. M mode ultrasound can trace of normal diaphragm movement. In inspiration, movement is caudal, with the corresponding M mode trace being upwards as the diaphragm moves toward the probe. In expiration, the end mode traces downwards as the diaphragm moves away from the probe. Technique for the assessment of the paralysis of the diaphragm continue. In M mode ultrasound, a normal diaphragm, a sharp upstroke is demonstrated when the patient sniffs. Technique for the assessment of the paralysis of the diaphragm continue. M mode ultrasound can trace of paralyzed diaphragm. A paralyzed diaphragm demonstrates absent movement with respiration and sniffs. Pleural effusion. Pleural effusion was the first pathological alteration of chest visualized by ultrasound. Pleural effusion continue. The ultrasonographic hallmark of pleural fluid is an echo-free, red arrow, zone between the parietal and visceral pleura. This may be detected through both intercostal, beta, or abdominal approaches. The use of a direct intercostal approach with high-resolution linear array transducers allows the detection of even minute amounts, as little as 5 milliliters, of pleural fluid. Pleural effusion continue. The diagnosis of large and medium pleural effusions is easily made by ultrasonography. However, small amounts of liquid, especially those located between the chest wall and diaphragm or in the vicinity of a hypoechoic pleural thickening, are detected with great difficulty. Type of pleural effusion. The sonographic appearance of pleural effusion depends on the cause, nature and chronicity of the collection. 4 different appearances are recognized. 1. Anechoic, example, heart failure. 2. Complex but non-septated, example, parapneumonic effusion. 3. Complex and septated, example, tubercular pleural effusion. 4. Echogenic, example, empyemothoracis. Complex and septated pleural effusion. Sonographic signs of pleural fluid. 1. Echo-free zone separating the visceral and parietal pleura. 2. Echo-free zone displaying a change of form during breathing. 3. Floating and moving echogenic particles. 4. Moving septations within the pleural space. 5. Moving lung within the fluid. 6. Fluid color sign, on Doppler sonography. Floating and moving echogenic particles with moving lung within pleural fluid. Fluid color sign. The fluid color sign is a color signal detected by Doppler sonography that appears due to fluid movement in the pleural space during respiratory or cardiac cycles. It has a high sensitivity and specificity for detecting minimal or loculated effusions. Characteristics of various type of pleural effusion. Transudates are almost invariably anechoic. Exudates may appear anechoic, complex, or echogenic. Mobile strands of echogenic tissue and septations are frequently observed in inflammatory effusions. Empyema can result in an echogenic collection that mimics a solid lesion. Malignant effusions are more frequently anechoic than echogenic. However, a firm diagnosis of malignant effusion can be made only if there is associated nodular pleural thickening. Ultrasound staging of empyema. A. Grade 1 effusion showing anechoic fluid. B. Grade 2 effusion showing echoic fluid without septations. C. Grade 3 effusion showing multiple thick septations. D. Grade 4 effusion showing multiple septations with solid appearing components comprising more than 1/3 of the collection. Examples of pleural effusion. This sonographic view showing consolidation, C, with parapneumonic effusion, PE. L, indicates lung. Consolidation is indicated by air bronchogram, which has appeared here as multiple white spot. A large anechoic effusion with passive atelectasis of the underlying lung is seen. B. In this complex and septated pleural effusion, the dependent part of the effusion shows increased echogenicity. Note the thick septations within the effusion, arrows. C. In this patient with an empyema, note the diffusely echogenic pleural effusion. Malignant pleural effusion is characterized by nodular, irregular metastatic lesion over parietal pleura. Encysted pleural effusion. Encysted pleural effusion having moving septations, green arrow, within the pleural space. Free fluid position change according to patient's position, but encysted fluid does not change according to patient's position. Measurement of pleural fluid. There is no authentic method for detecting accurate volume of pleural fluid collection, but yet several modalities help to measure the volume of pleural effusion by means of sonography. The best accuracy is achieved by planimetric measurements of the square dimensions of effusions in various longitudinal and transversal sections. Various formula for measurement of pleural effusion. For sitting patients, a good method is to calculate the sum of the basal lung to diaphragm distance equals A and the lateral height of the effusion B, and to multiply the sum by 70. A plus B, x 70 equals amount of pleural fluid in ml. In the supine patients, the measurement of the volume is made using the formula 50xb 800, where B is the thickness of the dorsal fluid layer in millimeters measured at a right angle to the chest wall. The fluid volume can be calculated by measuring the maximum perpendicular distance between the surface and the chest wall. The scan is performed with the patient in the supine position, at maximum inspiration. The measurement is made right above the diaphragm. Or in simplified way, if the distance between chest wall and lung surface, B, multiply by 20, an average amount of pleural fluid can be calculated. That is V equals Bx 20. Sonographic anatomic classification based on quantity of pleural effusions, in longitudinal scan from the posterior axillary line. Grade. Relation of lung with pleural fluid. Landmarks. Relation of upper limit of pleural fluid to intercostal spaces. Grade 1, minimum. Limited to costophrenic angles. Diaphragmatic dome partially evident. Limited to costophrenic sinus. Grade 2, small. Lower lung lobe partially involved. Diaphragmatic dome completely evident. 1 intercostal spaces. Grade 3, small to medium. Lower lung lobe partially collapsed. Lower lung lobe partially atelectasic. Pulmonary hilum not visible. 2-3 intercostal spaces. Grade 4, medium. Lower lung lobe completely collapsed. Atelectasis of the lower lung lobe. Pulmonary hilum visible. 3-4 intercostal spaces. Grade 5, large. Upper lung lobe partially involved. Atelectasis of the lower lung lobe. Upper lung lobe partially atelectasic. 4 intercostal spaces or more. Grade 6, massive. Lung fully collapsed. Atelectasis of the whole lung. Hilum completely visible. Ultrasound quantification of pleural effusion. Quantity of pleural fluid. Ultrasound visualization. Volume estimation. Minimal. Only costophrenic angle fill with fluid. 100 milliliters. Small. Fluid up to 1 probe range. 100 to 500 milliliters. Moderate. 2 probes range. 500 T0 1500 milliliters. Large or massive. 3 or more probes range. 1500 milliliters. Thank you all. End of part 2. Role of ultrasonogram in chest disease part 2. Learning pulmonology.